think we can get started. So welcome. This is our first summer webinar series. My name is Tara. I'm a program coordinator for Central New Hampshire Community Opioid Response. Today we are going to be discussing medication-assisted treatment, path to recovery, and local resources with our speakers, Dr. Andrea Berry, Corey Gately, and Daisy Pierce. Just a couple of housekeeping items. Please mute your phone or computer if you're not speaking. So there'll just be the speakers when it's their turn will unmute, just so we don't have all the background noise. And please submit any questions for the Q&A session at the end into the chat box, and I will read those for the presenters. So just a little bit about our program, Central New Hampshire Community Opioid Response, or you'll sometimes hear it called CNHCOR. This is our mission and vision statement. And I'll let you guys, I don't need to read it to you, but if you just take a look at that, our program is made possible by a 3-year Rural Community Opioid Response Program grant from HRSA. And the organizations that you see below there, CADY, Mid-State, Spear, Park, and Lakes Region Mental Health Center are our partner organizations and all have representatives on our board. Our next opportunity will be July 29th, same from 12 to 1 p.m. and it'll be on drug court and restorative justice. Annie Crowley and Rhonda Bishop from the Grafton County Drug Treatment Court and North Country Health Consortium, and Douglas Moorhead, who is the Director of Restorative Justice for CADY. And I will put the link to register to that in the chat box, and I will also send all the attendees our flyer and promotions. All right, so up first we have Dr. Berry. Make sure she's not on mute here. Dr. Berry, you there? Can you hear us? Not sure if she's having technical difficulties. Dr. Berry? It doesn't look like you're on mute. It might be on your end. Give us 1 second here. Okay, she's having some audio difficulties. All right, she's gonna try coming in with her cell. I apologize. Why don't we, while we're working on those, Corey and Daisy, would you be willing to go first?
Sure.
Okay, and we'll figure that out.
I just spoke for Daisy there. Are you willing to go first, Daisy?
Okay, we'll do that. I apologize, everybody.
So Dr. Barry is going to do it from my login.
Okay,
But Daisy can certainly go first if she wants.
okay, we'll do that. Take it away.
Okay. Hi, my name is Daisy Pierce. I am the Executive Director at Navigating Recovery of the Lakes Region, and we are a recovery community organization in Laconia. So we are similar to PARC, Plymouth Area Recovery Connection. So in the same sort of vein there as far as what we do for services. And then Corey, I'll let you introduce yourself before we go to the
I'm
next
Corey Gately. I'm a MLADC, and I'm the Director of Substance Use Services at LRGHealthcare. I oversee our medication-assisted treatment program at both Lakes and Franklin, and I'm also the Director of our Doorway at LRGHealthcare.
Okay, we can go to the next slide. So oftentimes when Corey and I present, we are asked why we don't do more in the prevention section of the continuum of care. And so I like this graphic simply because it sort of highlights the piece of pie that Navigating Recovery focuses on. Although we work very closely with treatment and prevention and intervention, our area is recovery. And recovery can mean different things to different people depending on what their area they're coming from. But for us, we recognize it to be a lifelong journey. It is something that people have to work at every day. It is work. It's a life free from alcohol and other drugs. It's an area in which someone can give back and have a sense of purpose again to their community. And so we really like to focus on all of the positive things that recovery can bring. And so we often say that recovery brings back what addiction has taken away. So Corey comes more from the treatment side, and Dr. Barry also with medication-assisted treatment. That's that piece of pie. And then if you think about any local, like Stand Up Laconia or things like that, that's the prevention side of things. So here's our continuum of care, and we all work very closely together. And it's not even always a simple cycle. Sometimes things get crisscrossed, but we all do work together. So Corey, did you want to add anything to that, or?
No, I think you said that nicely. I think that your point, though, about how people will often say to us, like, what are you doing, to help intervene in schools? And, we're really focused in the places that we're focused. A lot of the work that we do in treatment and recovery, though, it's important for all of us to acknowledge that we are doing prevention and intervention in some ways. When we're treating parents with children, that's a form of prevention and intervention for those kids. So the cycle certainly makes sense.
Yeah, exactly. Recovery is prevention for the next generation. So next slide. So one thing that we strongly support at Navigating is multiple pathways to recovery. If we had a one-size-fits-all solution to this problem, we would not have the crisis that we do today with substance use disorder. So we try to offer as many options to individuals that come to us. And so we do work with individuals with substance use disorder, as well as anyone else in the community affected by that. So friends, family, coworkers. And so some of the options that we provide are, we do crisis navigation. When someone walks through the door and says, I'm ready for recovery and I don't know where to start, that's a place where they can come to us. Sometimes that means getting them to detox. Sometimes that's inpatient residential treatment. We also help people with referrals to intensive outpatient programs, or IOPs. We get referrals for medication-assisted treatment. There are group meetings such as Smart Recovery, 12-step, right? NA and AA, for people who are familiar with 12-step meetings. 3 principles. We've recently added a Buddhist recovery meeting. So we try to have as many different options as possible when it comes to meetings and pathways, because we figure that the more we offer, the more likely it is that someone will find what works for them, or a combination that works for them. And so, you know, just like we're all different in our tastes and styles of clothing and food and, you know, lifestyle, exercise and things of that nature, we're also very different in what works for our recovery. We also offer art therapy, yoga, and meditation. And the primary service we have at recovery community organizations like Navigating is peer support coaching. So that's one-on-one coaching from a person who oftentimes is in long-term recovery themselves. So we like to use that because it really breaks down the barriers. There's no judgment there. Someone has walked the walk and knows where somebody is coming from when they're sitting across the table from them. So that's on the left side of our chart here. On the right side, we have the same similar sorts of options for family and friends. So we do coaching for family members and friends. We have educational workshops for understanding and self-care. One, we think it's important that family and friends, coworkers, community members understand the disease of substance use disorder, and we help them to recognize that it's not a moral failing. And so we like to do workshops and education around that to help somebody come to that understanding. We also say that you can't pour from an empty cup. So we do a lot of work on self-care when it comes to loved ones, simply because if you're trying to be there for somebody you care about and you aren't there for yourself, you're not gonna have anything to give when they need it. We do group meetings for family and friends as well. We have a Smart Recovery for that, and the Buddhist meeting incorporates that. And then again, they're welcome to come to art therapy, yoga, or meditation. So those are some examples of pathways for recovery. Next slide. So there are, let's see if I can get this right, I think 14 recovery community organizations now in New Hampshire. If you go to nhrecoveryhub.org, you can see a map of where all of us are. Like I said before, Park is your local RCO, and so we're similar, but we're in Laconia. So as I kind of went over on the last slide, we're that place to start a recovery journey. If someone doesn't know where to begin, they can come to us and they'll be greeted warmly and meet a whole bunch of people that, you know, have been there before. We host all of those different types of meetings. I always forget this, Corey reminds me, we are a nonprofit, so everything we provide is entirely free. We do not charge participants for any of the services that we provide. So price point should not be a barrier for someone coming to seek help, and that's important to us. So like I said, it's free peer-to-peer recovery support services across the board. And that goes for all of our workshops and educational components, art therapy, meditation, all of it. So one thing that I didn't mention about the peer-to-peer services is all of the coaches at Navigating now are certified recovery support workers. So a CRSW is someone who has taken the 5-day CCAR Academy, which is a recovery coach academy. They've taken a 2-day ethics training, an HIV training, and a suicide prevention training. So in addition to having lived experience, they also have quite a bit of training and education that comes along with that. They've completed 500 hours of supervised direct services. They've also completed 25 hours of clinical supervision. They've passed an exam, and the state of New Hampshire has licensed them so they can bill Medicaid. So it's a really neat career path that can be created from somebody's journey on recovery. So that's what the staffing is at Navigating, our CRSWs. So well-educated with lived experience. Next slide.
So I'm going to talk a little bit about the doorways and what the purpose is. And one of the reasons that Daisy and I often are presenting together is because we work so closely Our doorway is staffed with a CRSW for all the hours that we're open, and we are subcontracted with navigating for that CRSW. So here in the Lakes region, the way the system works is that we have coaches that are contracted to our hospital. We have a 24/7 hospital support program. So if somebody were to come into our emergency department, or even if someone's in our hospital in need of speaking to a coach, we are contracted with navigating, and they'll be able to do that. But we also have those coaches in our doorway for the hours that we're open. And so the purpose of the doorways when we first developed the doorway system was to make sure that anyone could connect to services within an hour of where they live. And so every doorway is situated so that, you know, they cover like an hour outside of their range. And so our doorway, the Lakes Region, the LRGH doorway is the one that services Plymouth. I'm going to give you a little bit more information about some of the things that we've done more recently. And so that you understand a little bit better how people can connect to us from the Plymouth region. And really the doorway's purpose is to help people navigate community-wide resources and to break down barriers. We often tell people that when they come to the doorway and they're seeking substance use services, we want to make sure that there are no bumps in the road so they don't have any pitfalls in making it there. And the example I always use is this: if somebody comes in and they need to get into an inpatient bed, that's what our clinician deems is necessary. They'll have an evaluation same day. If they don't have a ride, we're going to make sure that they have a ride. If they don't have a physical done before they get there, we're going to really work on making sure they get that physical done so they can get to treatment. We just want to take away all the pitfalls from a doorway perspective. And so it's important to know that the doorways, at least for the next few months, are funded to treat folks who have opiate use disorder or who are at risk in any way for opiate use. And so that's been really specific when it comes to the doorway system. That is going to change. Round 2 of the doorways, we should have funding and be able to help people with crystal meth. And as much as we wish that it was expanded to all substances, it hasn't been yet. That's not to say that we wouldn't want someone to call 211 if they were dealing with any substance use issue, or even a family member who's dealing with not knowing what to do next. We would tell them to please call 211. 211 will connect someone to their local doorway, and then we can start helping them from there. The only thing that we can't do is if we're working with someone who, let's say we have someone who comes through the door and is seeking services and they've never ever had any opiate use history and they're not at risk, and so maybe they're strictly alcoholic. Would we help them? Absolutely, we would help them. Will we go through all the same processes that we do now? Absolutely, we will do that. But we have funding that helps us financially to help people get places like rides and things like that. And we wouldn't be able to do that under the funding now. We're hopeful that that will change in the future. So the doorway is really a place for people to begin the process, talk to a coach, talk to our patient navigator, have an evaluation done by a clinician, which we're doing entirely remotely, the clinician piece right now. But it's really a place to get started with connecting to treatment services.
And Corey, can I just jump in for a second there?
Yeah.
So I think one of the questions that we're often asked is, you know, what's the difference between the doorway and a recovery center? Where do I go first? And truth be told, there's no wrong door, right? Even though it's called the doorway. When we have these really close partnerships like we do in these communities, we will get you to where you need to be, and we will be able to help you however we can. So if you walk into navigating first, and it turns out that you need an eval, we get you up to the doorway to get that eval done right away. If you go to the doorway first and you get services there, and then you need longer term follow-up care, you can get a recovery coach and come to navigating the next day. So, you know, it's pretty seamless between us. It's one of the things that we're proud about, our community connections, but there is no wrong door. So no matter where you go, people will help with, you know, getting you to where you need to be.
Thanks, Daisy. Next slide. So the hub and spoke model, which is how the doorway was first started, was that we wanted to make sure people were connecting to a place so that we could help get them connected to other places. The doorway doesn't technically provide treatment, but it can make make it simpler for people to connect to treatment, and it can provide a really safe place for people to get started with learning about resources and learning how to manage to get connected to resources. I feel like I date myself in this field whenever I say that, like, years ago, if you were trying to get into an inpatient bed, those of you who have been here in this field with me for a while, I see all your names in my participant list here. You know you're out there. It would take weeks, if not months, for people to even be able to connect to treatment. And so the doorway system really is interesting in the sense that if somebody walked in this morning, they'd see a coach and they'd walk through the whole beginning part of that process about what they need. We would connect them to our clinician. Like I said, we're doing that remotely with our clinician, but all the rest of what we're doing is face-to-face right now. They can have an entire evaluation done, and we have people that we are seeing placed into either a respite bed or an inpatient bed by the end of the day. So that's pretty great when you think about how it used to be. We can go ahead to the next slide. And then the doorway flow is there's access points, and like Daisy said, no wrong door. People can call 211. They can be referred over to us by probation or parole. We have family members calling. People hear about us in the community, primary care, and they can literally come directly through the hospital or come to the front desk at our hospital. The initial services that we provide are screening, clinical evaluation. We do have Narcan, and we literally just hand it out to folks. And then we work on referring people off to where they need to be. Those referral sources are substance use treatment, mental health programs, primary care, housing, medication, and peer support. And is that our last slide, Tara? Yes. So I just wanted to say before we move on that one of the things, I know Wendy Williams is on here, she and I just spoke this morning. One of the things that our doorway was trying to do in the Plymouth region was build some way for us to see people through Park and through Midstate virtually. And Wendy and I were laughing about this morning because we spent somewhere more than 6 months trying to make a virtual platform so people could come in to Park and connect to the LRGHealthcare doorway virtually. We literally spent months and months and months trying to make this happen. And then the pandemic hit, and really within a matter of days, everyone had virtual access to everything. So, and we had just signed our contract and made that so that we could do that. So now our hope is that when people come in the Plymouth region and they're in need of doorway services, we will be able to connect them virtually and start working with them in that way. The problem in the doorway flow is that we need to be able to have the clinician, the clinician has to be sort of out of our doorway. And so that was kind of the glitch we were working on. So now we're going to be doing that in a way that really reaches more people. I think we have to change things in rural health so that we are able to reach people virtually. So I encourage everyone to hop on board with making sure that we keep some of the ways that we've changed things for the pandemic so that we can continue to reach people virtually. So that's where we're at as far as what we do with the doorway. Do you want us to take questions right now, Tara?
I think we'll wait until the end. Let's let Dr. Berry go. You ready, Dr. Berry?
Sure.
Yay, we can hear you.
Sorry for the delay.
There's always a technical issue. Yeah,
Absolutely.
No worries.
It actually worked out. I'm glad that Corey and Daisy got to go first because my piece that I'm going to be talking about the medications is just one piece of what we do here. It's just another tool that we have in our tool belt, but certainly medications are helpful, but they're not certainly the be all end all of treatment. So I think knowing what the other resources and everything else that's going to help patients is as important, if not more important, than my piece. So I'm going to talk about the medications. They're just kind of briefly touch on the three classes of medications that we use to treat substance use disorder. But just kind of a general reminder. Unfortunately, we hear a lot, and I'm sure you guys hear it every day, that, with Suboxone and with medications, we're just, sort of replacing one addiction with another, right? We hear that all the time. But patients who are actively using and are in crisis, if you're asking them to participate in therapy and work on trying to get a job and go see their primary care to get their depression under better control, and they're withdrawing, it's just not possible to do those things. So the medications really are intended to be sort of a bridge. So we make people feel, I hate the word normal, but quote unquote normal, so that they can kind of participate in all these other things that are ultimately going to help them in long-term recovery. And then hopefully at some point we can come off the medication. Sometimes we can, sometimes we can't. But if we continue to focus on this idea that substance use disorder is a chronic condition, as with any other medication or any other condition, the medications are a piece of it, but they're not, they're not a crutch and they're not a replacement for currently, for active addiction. So that's just kind of my general plug, because unfortunately, there's still a lot of stigma with medication. We have a lot of patients who just aren't interested in it because they're afraid they're going to be judged. Even within the recovery community, there's a lot of stigma still. So just trying to get that message out there and loud and clear. As far as the medications, there's kind of three categories of meds that we use for substance use disorder. The first one is what we call a complete opiate agonist, so that's methadone. So methadone works the same. Methadone is an opiate, so it works the same way as opiates do. It binds the opiate receptors in the brain and it activates them, it stimulates them. So the potential problems with methadone are the same as they are with any opiate. So overdose is a big one, sedation, physical dependence, and addiction are kind of our big issues with methadone. The one good thing about methadone, because of the way the methadone programs work in the state, it's daily dosing for the most part. So for patients who are just struggling with, you have to have a certain amount of ability to control your medications when you're on Suboxone, because often with Suboxone you're ultimately given a month prescription, and for some patients that's just not possible, especially at least early on in recovery. So sometimes methadone can be used there. I tend not to use methadone because of I think the risks outweigh the benefits, but for the right patient, methadone is certainly a reasonable choice. The medication that I tend to use, which is the second class of medicine, is where Suboxone falls, and that's what we call a partial agonist. So by saying that, it means that Suboxone binds to those opiates receptors in the brain, and it stimulates them a little bit. It's sort of like a weak cup of coffee, right? It's better than nothing. You're going to get some of that caffeine, but it's not going to be as much as, an extra shot of espresso. So by doing that, as far as your body is concerned, those receptors are full. So you're not going to have any withdrawal symptoms, theoretically. And theoretically, you shouldn't have any craving for the drug because, again, those receptors are full, body's happy, brain is happy, so that people can go and really participate in counseling and participate in their recovery and feel sort of normal. Because it's a partial agonist, you certainly do become physically dependent on Suboxone as you would with any other opiate. So the process for Suboxone is a long one, and once the coping skills have been learned and got a good job, got a good place to live, everybody's stable, the hope is eventually to taper off the medicine. That doesn't happen quickly. It takes a really long time. As I said, our goal for everybody is to taper off. Again, if you look at it from the chronic disease model, then maybe we shouldn't be tapering everybody off, and maybe we should, maybe they're stable because partly that they're on the medication, as somebody with high blood pressure would be stable on their blood pressure medicine. We don't take them off their meds. So there is kind of two schools of thought there. Some, the goal I think is still to come off, but for some people, they may never come off of it completely, but the goal would be to kind of taper down to that lowest dose that we can kind of maintain. And then the third category of medicine is what we call an opiate antagonist. So that would be naloxone or naltrexone. So those medications just block the receptors in the brain, so there's no stimulation, there's no activation. So the benefits there's no risk for overdose. You can't really hurt somebody with naloxone or naltrexone. You can make them mad if you put them into withdrawal, which is what it would do if somebody has an opiate in their system. But you can't really hurt anybody. In my opinion, naltrexone is a good measure for people who are a little bit in longer term recovery once they've come down on Suboxone or on really, really low dose, or even methadone. For some people, they're just so fearful to change, that last bit once, because everything seems so much more stable and they're feeling so much better. So I think it's sometimes a good option for people, because naltrexone, once it's in your system, will will block any opiate you take. So if you take an opiate, theoretically nothing's going to happen if you have naltrexone in your system. So for a lot of people, it's just kind of a good reminder that it's there. Because it doesn't stimulate or activate the receptors in the brain, it doesn't really, I find, is not that helpful for cravings. So for people who are in early recovery, a lot of people don't tend to do well. There are some people who use it, and there are certainly some people who do well with it. But where I find it to be most useful is further on in recovery, as kind of as a bridge from being on Suboxone to being on nothing. So I know that was just a really kind of quick overview. I'm certainly happy to take any questions about the medications. There's no right way to do this. There's no one medicine that's perfect for everybody, and it's just very individual, based certainly on what the patient is looking for, what they want, obviously, is the most important thing, and then certain, just depending on a bunch of other factors, it's kind of how we determine what the right path is for each patient. But like Corey and Daisy said, there's no right way to do this. There's no one doorway. There's no one medicine that fits all.
Perfect. Thank you so much, Dr. Berry.
Sure.
So I am going to stop sharing here and check out our chat box.
Cara, can I jump in with one piece to add on to that?
Absolutely.
Just to sort of tie that into a neat bow, I know that Dr. Berry and I have had a lot of conversations, and I feel like our medication-assisted treatment program is really very much on the same page in a lot of ways. And just to tie that sort of all together, one of the things that Daisy and I talk about this a lot is when you have someone who's got a new diagnosis of something, I think we very often in the medical field, right, we make sure that someone starts in a place that's manageable for them, right? So if somebody comes in and they have high blood pressure and we tell them that there's 10 things they need to do to change their lifestyle, we may start with medication. And a few weeks later, when they're feeling better, they may be in a much better place to start making some of the other changes. And I think even years ago in MAT, right, we were really staunch with people about you have to start the medication, you have to get to your counselor. In fact, you probably even need to get to your counselor before you start the medication, or we won't see you. And I think we flip-flopped a lot of that so that we have a better understanding that sometimes the medication is the thing that catapults people into having the ability to do all the other steps. And so when I say tie it together, often what we have is people who are accessing places like a doorway or a RCO and starting to talk to a coach and saying maybe medication would help. And I feel like places like Midstate, Dr. Berry, places like LRGH, we're working really hard to make sure that we get people to MAT as quickly as we can, so that we can start getting them to do all the other services and take on all of the other pieces. I just had someone today who, we're probably a month into medication, who finally said, I've got some things I need to talk to a counselor about. Hallelujah, let's get you to a counselor. But I think if we had set that out right at the beginning, you have to see a counselor today while we're starting this medication, I think we would have lost him. So I think it's just a good thing for us to sort of tie together how all these services are working closely.
Great, thank you, Corey. So please enter any questions in the chat and I will read them for our presenters. We do have 2 in there right now. So seeing more patients who report that they need Subutex rather than Suboxone due to allergy, etc. What are your thoughts on that?
Yeah, so we see a lot of that too, unfortunately. So Subutex is just buprenorphine, so it's the active ingredient in Suboxone. It's that partial agonist that I was talking about before. Suboxone is a combination of buprenorphine plus the naloxone, which is the blocker. Unfortunately, when you take the blocker out, there is a much higher abuse potential. So I'm not a fan of Subutex. I don't use it. So if you I actually did research on this not that long ago because I was hearing a lot of that too. And any side effect that's listed as possible for buprenorphine is also listed as possible for naloxone. So for me, I kind of struggle with that. So I have not been doing Subutex. For me, it's almost a hard no. There is a new injectable version of buprenorphine is a once-a-month injection called Sublocade. So for patients who are insistent that they can't take Suboxone, we can certainly look into the injection. And it's just, you know, you try to take patients at their word, and do I think everybody's lying to me? No, of course not. I mean, there are probably some people who truly do have an allergy to the naloxone component. My concern for that would be, however, if you can't use the naloxone, then theoretically we can't reverse you know, any potential overdose, which it's really hard to overdose with buprenorphine because buprenorphine has what's called a ceiling effect. So once you get to a certain level, no matter how much you take at that point, you're not going to get any additional benefit. But if I can't reverse that, then that's a little fearful for me. And that's kind of how I pitch it to patients. But it is a nice option now that we have Sublocade. It's buku expensive and really hard to get covered. So it's kind of a pain in the butt. But for patients who truly feel that they can't take Suboxone, they're willing to put the time into it. So that's kind of the way I've kind of gone around that.
Thank you. There's been a higher use of methamphetamines being seen locally. Are there any sort of MAT type options for that?
So unfortunately, at this point, there's not really, we don't have a Suboxone-like medication for methamphetamine. We are seeing a lot more methamphetamine. I think we've done a really good job in the last couple of years of helping people to understand how dangerous fentanyl and heroin are and that you could die. We have not done a very good job of explaining to people that methamphetamine is not a good option to switch to. It is equally dangerous. But unfortunately, right now, we don't really have medication that we can use for methamphetamine addiction. Really, the treatment is counseling and most likely inpatient. So that's kind of where we're directing people if they don't have opiate dependence along with methamphetamine. Oftentimes with people who are using meth and opiates, if you can get the opiate under better control and get the counseling going and that sort of thing, oftentimes we can get the meth part under control as an outpatient, but not always. But for patients who methamphetamine is their drug of choice, really the treatment is inpatient at this point.
Thank you. Can you speak to additional supports for expecting mothers in the area for MAT?
Want me to jump in?
Yeah.
That's fine. Expectant mothers, there's a couple of programs throughout the state. I'd say one of the things that, I mean, we really don't have a lot that we're able to do in this region, like as far as programs, but we're certainly strongly encouraging that expectant moms are in treatment with MAT, are in treatment in our, our local organizations if we're able to, like IOP level of care, if that's what they're appropriate for. Certainly we're making sure that they're connected to our doorway to make sure that they always have the services that they need, so that they're not, again, falling through the cracks, like I can't get to this appointment, well, because I didn't have a ride, because I didn't call CTS soon enough. Well, the doorway is going to call a cab and make sure you make it to that appointment. So we're certainly trying to wrap our arms around our expectant moms, our young moms, and making sure we keep them connected. I think that's been sort of an interesting piece of watching moms on MAT, and I wonder if Dr. Berry can also agree with this. I think years ago we would see an expectant mom deliver and then fall away from treatment, and I think we see a lot of moms today who stay right with us, and they continue to go to treatment and counseling. They continue to stay on their medication, and that's been sort of a beautiful thing to watch them stay with us and really parent even after they don't need to have, even after they're not pregnant any longer. So I think that we're just trying to make sure that we connect them to our coaches, our recovery community organizations. Lots of the parenting classes, I think, we've got a lot of parenting classes in our area. Those have been a good thing, the parenting journey. And so we're really just trying to make sure we really connect them everywhere. Daisy, do you have anything to add to that?
No, I was going to mention the parenting classes because I see Trish is on here, or she was.
Yeah.
Behind my chat box. And so, yeah, we also work closely with the Family Resource Center to provide those parenting education. And so I think that's a big part of what we do here in the community.
Great. It's from Ryan Fowler. I coordinate a syringe service program in Sullivan and Grafton counties. Are there harm reduction services in the Laconia region? there's a few questions in here. Do patients report issues with syringe access or infections from injection drug use? Do local pharmacies or providers dispense syringes without a prescription? Stimulant antagonist therapies for stimulant use disorders, off-label prescribing. I'm trying to pronounce these.
Sorry. So
Modafinil.
the second one was just a response to the treatment for methamphetamine use. There's a lot of
Oh, okay.
conversations about therapies,
Gotcha.
but the first part was my question.
Yes.
So harm
Syringe
reduction in
services.
I'll respond to harm reduction in our area. I'm sure Daisy will too. I feel like some of the biggest things that we're doing are, from the doorway into treatment, we're like breaking down every barrier possible. If somebody wants to start in our recovery clinic, which is our medication assisted treatment program, it's literally a phone call, either to Navigating Recovery, to 211, to the doorway. And those places will tell us that they're calling for an appointment. They will call us and they will have an appointment, very often same day, if we're able to. So we're trying really hard to make sure that people are accessing those services quickly. We've been doing medication assisted treatment inductions in our emergency room for, I think I've lost count. I think it's 2 years now that we've been doing that, and having our recovery coaches in our ER for upwards of about 3 years now, right, Daisy? And so we're trying really hard to make sure that we're getting people quickly into those services. When we talk about other harm reduction services, we do not have a syringe service program here, which we think is unfortunate. And so that's one of the pieces we definitely are not doing. To answer some of the other, if they can access syringes at our local pharmacies, yes. And if they're in our MAT program, those pharmacists are very often letting us know, which I think is good because it provides us with an opportunity to talk to the patient when they come in. The majority of them are getting them for someone else. That's what they tell us. But it is a great opportunity for us to then start a conversation with people that this is that we know. I think harm reduction wise in our program, we work really hard to make sure that folks know that they're not gonna, if they come in with a positive drug screen, they're not getting kicked out. When I'm not managing my asthma well, I don't get kicked out of my doctor's office. And so we want them to come in and talk to us. That's an opportunity for us to figure out how to do this better, how to help them, how to get them to where they need to be. And so we've come a long way in our ability to make sure that people can talk to us about how their recovery is going, even if it's not perfect, and we'll continue to work with them and stand by them. And there was another piece in here too. Patients report issues with syringe access, infections from injection drug use. I know at our hospital, when we have folks who come in who have infections, we have a whole team of people that meet now to make sure that we're providing them with the social services that they need. If they're inpatient, they're getting to meet with people on that team. Our social workers have all been educated and brought up to speed on the services and what we need to do. We're connecting our coaches from the doorway to someone who's inpatient to make sure that we're starting to work with them, especially if there's someone who is staying for like 6 weeks of IV antibiotics. We're trying to connect them to services while they're in that bed. Because can you imagine being in a hospital bed for 6 weeks? We're trying really hard to make sure that we're talking to them and staying with them through that, and then connecting them wherever they need to be after that. As much as all of those things are great, we have a long way to go in this community, I think, with syringe service and things like that. What else, Daisy?
Well, I was just going to add that I've definitely heard Ryan speak before about the syringe service programs and getting excited about doing something like that in Laconia. I think the challenge that we have encountered is as a recovery community organization, we can't use our 501c3 to do that. And so finding staff and volunteers in the community who are willing to do it weekends and after hours. And unfortunately, a lot of my staff is on call 24/7. So they don't have as much after hours and weekends time to go out and do a syringe service program. But we do have the patient navigator at the doorway who wants to help start one. So we're really trying to figure out how to do this so that we're still following the letter of the law, as far as the 501c3 is concerned. and not exhausting the staff that we have in the community to the point that they can't provide the services to the level that they want to. But I always get inspired when I hear you speak, Ryan, so it's on our to-do list.
Yes.
And Corey, the one other thing I think you should
contact.
Yeah. Corey, the one thing that you didn't mention that I think is very important to harm reduction is how far we've come with our homeless services here, as far as recognizing when someone needs housing first and maybe can't pass a UA, has a positive, and the services we've done for that.
Right, so we've worked really hard with our local homeless shelter to do some education and have a really good connection from our doorway perspective around that, because there's been a lot of hard and fast rules in the past, and those don't always work. When we have someone who comes in and they're really motivated and struggling to even get a few days of sobriety pulled together, really getting them housing first might be the thing that works. And so we've made this great connection with our local homeless shelter to manage to help people put a roof over their head, get them a hot meal. And in most cases, what we're seeing is that people are doing really well because they've been able to put their head on a pillow and then work on sobriety. So we're trying to break that down a little. Thanks for remembering that, Daisy.
I know that there's a lot of concern in the central New Hampshire region about transportation. Can you just talk a little more about how you can handle that?
Yeah.
With people from this area?
Yep. So the doorway, I can speak from a doorway perspective too with some of our state meetings. I can tell you that all these things you're bringing up are things that continue to come up in our state meetings at the doorway level. And those things include syringe service programs. It also includes the fact that we have a region, Concord, that doesn't have a RCO to even be near their doorway. And so these are concerns that we know have to be addressed as we go down the roads with the doorway program. And so transportation has always been a big issue. I still laugh about some of the first meetings we had because I think it was somebody at the Nashua doorway was like, why don't you use Lyft or Uber? And I was like, oh, we don't have that. I think from the Lakes region north, we just don't have a lot of that. So again, we've done some work with one of our local taxis, a couple of our local taxi organizations who are very committed to us. I feel like when the doorway calls, like we become their priority. And so we've worked really hard to make sure that we have a good connection with them. And they're really helping us to get people, when people go to respite, the closest respite is now in Effingham, and they will take them there. They are picking people up from there for us. They're taking people to treatment much further away than that. And so that's been really the best thing we've had, is a good connection with our local taxis so that we can get them where they need to be. Having the ability to do things virtually is already starting to help. So we have folks in places that they can't get to us, but they can get to us virtually. And so starting to help people, even though they may not be able to physically come to the doorway or physically even make it somewhere where they can connect, they can still connect to us from home. So we're trying to do as much of that without transportation as possible.
Yeah,
Transportation's tough though.
I don't think telehealth is going away, so.
I hope not.
Perfect. All right, does anybody have any final questions? Okay, I did put the link in the chat box for the registration for our next webinar, and also my email. So if anybody has any questions, please feel free to reach out. I can connect you to any of the speakers or any resource that you may need. And Ryan just put in some more information too about different pools of money hitting New Hampshire to expand syringe services, and some contacts there. So, well, thank you so much to our wonderful speakers. Peter Burke from Farnham has his contact info in there too. It was wonderful to hear from you all. It's great information. So we'll give people 10 minutes back on their day, and thank you all for attending.
Thank you for having us.
Thanks, Tara. Thanks for having us.
Bye.